If you're the best medic and you don't document, then
You're not the best medic.
And
go our brothers and sisters.
That's right, I hear 'em.
Go get them, brothers.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Here we are again, Matt.
Here we are again. Once again, we're talking about, we just filmed a lecture on this, and now we're going to talk about this in our podcast.
High risk errors.
Yes, errors. Yes.
Mistakes.
Yeah.
Lapses in judgment.
Yeah, we'll discuss like what are the most common errors,
Yep.
and then we can discuss some ways to prevent those errors.
Correct.
Very important. But before we do, if you listen to us, like, share, and subscribe to our podcast. Helps us out. Share this with other first responders that you know. I love it when my guys are like, I listened to your podcast the other day on this.
That's cool. What was the last one that we did?
Oh, gosh.
Do you remember?
What was? Oh, well, we can't say it. We can't say surprise.
Oh, what's the last one that was released?
Oh gosh, I don't remember.
Because I know we record and then we kind of store them up and release.
Yeah,
them,
we don't. Yeah, we don't always release them in the same order.
So I
that
can't
we
really
record.
say who we're having next, which is exciting. So I guess we'll just leave that.
That's
so,
right.
Okay.
And people always don't listen to them in order either. So
No, that's a good
it doesn't
point.
really matter. But yeah, like, share, and subscribe. So errors. There are some common errors.
Yeah, we did some research on this to look for the more common places where we make mistakes, these high-risk areas. There are a lot of different ways to categorize them or group them up. We've broached it in different ways.
Yeah.
I think the simplest way is there's evaluation errors, there's management errors, and there's system errors. I think that's probably the easiest way to organize it. Evaluation errors, I guess we could start there.
Yeah.
One of the first things that comes to mind, like we talked about in our lecture, right? How long can you live without food, Matt?
That's right. 40 days,
40
something like
days?
that.
Yeah.
Yeah, 30, 40 days.
Actually, I heard a story of a guy that lived for hundreds of days without food, and he just lived off. He was overweight, and he lived off of his
Lived
own
off his
fat.
His body was eating itself
He
for
was
100 days.
supplementing with nutrients,
Right,
water, and all
vitamins
that.
and
So
stuff, yeah.
Truly fasting, though, your body's got enough reserves about 40 days before you start really causing
I go about
harm.
4 hours and I'm starving.
I get hangry after, depending on the time of day.
Most firemen go about 4 hours and they're like, me, Mongo need food.
It's true because you get into that pattern
Yes.
of which we'll talk about actually as part of the system area. You get into a pattern of doing something.
Yes.
And you get
Becomes
hungry
a
really
habit.
quick. It gets a
Yeah.
habit. That's right. So, so 40 days without food, about 4 days without water,
Yep.
depending upon
Can't go long that long
circumstances.
without water.
But without air, boy, I can hardly hold my breath for a minute.
Yep. Yeah.
4 minutes maybe.
That's a long time.
I think I read, though, that about 6 minutes of oxygen deprivation and not breathing, you've got about 6 minutes, depending on metabolic rate and body temperature, before you start killing brain cells. So
Yeah, that's why those guys that dive do it in cold water.
that's right.
Yeah, slows down their metabolic rate. Yeah.
But the reason I bring that up, though, is that we don't have much time
No.
with airway evaluation and management. I guess we can kind of combine them both here. Evaluating an airway, whether you're a BLS or an ALS provider, it can be really high stakes sort of an assessment.
Yeah, and we're not really necessarily talking about, I mean, we are talking about assessing an airway for the difficulty of that airway, but we're talking more about potential for respiratory distress going into respiratory arrest, like looking for those warning signs that, ooh, this person's got a big problem here. I've got that COPD and I've listened and I don't hear anything. I've got a silent chest.
And they're altered.
Or I've got that kid with real bad stridor, and scaring me, wheezing, real bad wheezing, or even a silent chest on an asthmatic
It could
kid.
be even worse. That's right.
Yeah.
Be careful.
All those kind of things. Those are warning signs that, like we talked about, that our BLS providers, you need to be aware of those. That, hey, do I need to load this patient up? Do I have time to load and go right now, or do I need to call for more help?
Right.
And, if you have any options of doing things, different protocols offer different things for BLS providers. If you can give them epi, if you can bag or throw in a supraclavic airway. But you have to base that on your transport times, your protocols.
It's nothing simple.
Nothing simple, right? So everybody's a little bit different. And then paramedics, you need to decide, am I going to take this patient's airway? If you have that ability in your protocol.
Right.
you got to, and sometimes you got to make that decision really quick.
Well, regardless of what you can do for managing the airway, whether you're ALS or BLS provider, able to intubate or not, RSI, I mean, even ALS providers in some jurisdictions don't have that in their protocols. But the assessment, though, all of us need to be experts at airway assessment. You got to recognize the emergency, which is huge. And there are some situations where you may even be intubating while you're, with a patient that's talking to you. It's like, we've got to intubate you because your tongue's getting bigger. Yeah. It may be okay right now, but in the last 5 minutes you've described to me increasing tongue size. In the next 5 minutes it could completely occlude your airway, right? So
we need to figure that out pretty quick. One thing I teach my people is something that I watched you guys do in the hospital all the time. My new paramedics, because the reality is that guys have been doing this 5, they get into 10 years, and they start to get real complacent, especially with their assessments. Right. They get real complacent. Very rarely do you see, in my experience, paramedics listening to lung sounds on every patient. Right? Very rare that they do that. If it's a difficulty breathing, they'll listen to lung sounds. Correct. But just the run-of-the-mill patient, they don't always do that. But over my years, I would always see ER docs. You bring a patient in, it really didn't matter what they were being brought in for. Almost every single ER doc I've ever saw on every single patient, they will always do a quick head to toe. They will listen to breath sounds, front and back. They will kind of checklist, right? They will do a systemic checklist of their patient on every patient, regardless of their obviously if it comes in as a trauma, something, they're dealing with that, but we don't really do that a lot, and I don't think that's preached enough in the pre-hospital environment, and especially younger people when you're first learning, do an assessment. We've talked about this before. Secret Service, how do they know what a counterfeit bill looks like? Because they know what the real thing looks like. They've mastered
studied normal.
If you are constantly studying normal, you know what normal breath sounds are, you will know when something's not normal.
Same thing's true with heart sounds.
Heart sounds are the same thing. Abdominal sounds, same thing. All those things. And so I think that assessment, we take it for granted pre-hospitally. And because the reality is most people, fire-based EMS specifically, they didn't get into the fire service everybody to do EMS. Where everybody that's a doctor or nurse, obviously they know that's what they're doing for their job.
Of course.
But huge part of preventing errors, and obviously is the best thing for our patient, but it's us doing the right thing, which keeps us safe as well. Right, doing the right thing.
And I would say the common, when you're taking an airway, when I know that I can bag a patient, I have a certain amount of security in that, right? Because I can bag them all the way to the hospital if I have to. Meaning
that if you push paralytics, if you push sedation, you push rock on somebody, you're going to knock their airway out for 40, 45 minutes.
Right.
It's okay. I can maintain their SATs with an iGel or with, an oral airway in.
Exactly.
And
that's another big potential error is when we don't bag properly, whether you're bagging too much, too fast, or if you have a bad seal. These are some of the high-risk sorts of BVM situations.
What do you guys use in your department for BVMs? Do you have the full-size adults? I think there's 1,000.
I think we have the full-size and a pediatric.
Yeah, you got we used to carry the adult, the pediatric, and then the infant bags.
Yes.
So we've switched to, it's an adult child BVM. Yeah. And I'm pretty sure, if I remember, it's 500 mLs.
Sounds about right.
And again, even at that,
an adult doesn't. I mean, a huge person may need a little more than 500, but 500's good.
Yeah, and that's if you're crushing the bag. I mean, So that's another big thing. They've gone away, some departments have gone away from those big, huge, because, I mean, oh, man, you see that EMT kid?
Oh, yeah.
I remember walking into a nursing home one time, and a private ambulance company was in this nursing home that was in my district. We'd go there all the time, and we got called for a CPR.
Yeah.
And we showed up, and this big guy, he was the paramedic, and he comes out, and you can just see the stress is all over him, and he is sweating, and you can just see he is just freaking out. And he's got this young girl, this 19, 20-year-old girl, EMT partner, and she's so excited. She's in there, and she's bagging, and she's just bagging. And this guy he's just, because he's by himself, right? And so we walked in, and it was like, thank God some more other paramedics are here. And so, she was all disappointed when I was like, do you want us to transport the patient? He's like, would you? And I'm like, yeah, we'll take it, man. No worries. We'll handle it. And she was all bummed out. She wasn't going to get to drive Co to the hospital. But I remember her just crushing that BVM 50 times a minute, just thinking she was saving a life, man. She didn't know any better.
No.
But yeah, very important.
Yeah, sometimes too much of a good thing can be bad.
Yes.
Yeah, we got to be careful with tidal volume and rate and all that. That's good.
We talked about this in our lecture, but I think it's important to note here because I just saw this. You were talking about patients with beards.
Oh yeah, this is great.
I saw the social media post, and it was a picture of a guy with a big heavy beard because beards are very popular right now, right? And how do you get that good mask seal? Genius. I don't know who. I got to look up who this was that posted this, but they said take a Tegaderm and put it over the beard. And it'll give you that plastic to plastic seal. Yeah. It's probably not going to be a perfect seal, but it's going to be a whole lot better than that big thick beard.
It's brilliant.
Genius idea.
No, that's really good. I love that. Well, there's a lot of different airway concerns because it is such a high risk situation. Before we move on to medications, which is something else we're going to talk about, I was actually thinking about this driving to the studio today. So it's interesting to think about all the things that didn't show up in our research of looking for the high risk situations. Cardiac arrest, for example.
Oh yeah.
There's risk in everything we do, but why wasn't it one of the top 6 things, right? Well, I think a lot of it is because it's so protocol driven. We're so good at it, and it's something that's relatively common. We're talking about those high risk, high stress, high consequence situations that are low frequency.
Well, and in a cardiac arrest, I tell people this all the time, like cardiac arrests are pretty easy to, what the problem is. It's whether, am I shocking him or am I not shocking? Yep. That's really the only difference. Other than that, everything's the same. Yep. These situations, when you're trying to determine, do I need to take this guy's airway? Do I need to go to this facility or this facility? That's where that clinical judgment comes in, and that critical thinking comes in, and that's where experience plays a big part in it.
You're right.
But yeah, a lot more error prone. With those high acuity calls.
Another error-prone area is medications. Some of the medications that we've been authorized to deliver in the pre-hospital environment are very, very powerful medications. Medications that can completely paralyze you.
Yes.
Medications that could even potentially stop your heart.
Make you stop breathing.
Right. Yeah. So they're not benign. And used correctly, they're life-saving.
Yep.
Used incorrectly, they can...
Life-taking.
Oh, you watch the news, right? With ketamine.
Yeah.
You dose it wrong. You don't monitor your patient properly. These are deadly medications that can alter your physiology.
And a lot of those cases, not all, but a lot of those cases, something we'll talk about later, is that, a lot of paramedics have gotten in trouble, even faced some criminal charges, but they also tried to hide it and lie about it. And don't do that. Like, if you do make a mistake, you're going to make a mistake at some point on something, right?
You will.
Hopefully it's a minor mistake, no negative outcome to your patient. But you're going to make a mistake. And when you do, make sure somebody knows about it. Tell I'll tell you a mistake I had. I was on an ambulance and we were riding with a guy. Patient was having chest pain. And my partner was in the back of the ambulance with me. And I drew up some morphine to give the guy some morphine. And the way I do morphine is we would carry 10 milligrams in 1 ml, very common concentration. So to make it easier, because our dose was 2 to 4 milligrams per dose, right? A max of 10. And so I would drop the 1 ml of morphine and then 9 of normal saline. So I had 10 and 10. Very easy, right? Instead of doing 0.1, you just push an ml. So I mixed that up, handed it to my partner and said, hey, give him 2 milligrams of that morphine. I turned my back. I was doing something, and this is my fault. I should have been more clear.
Yeah.
And I turned back around, and as I'm turning back around, the whole syringe is going in. And I'm like, it's 10 milligrams of morphine. It's probably, then the guy's blood pressure was very stable. And he was a young guy. But still, I was like, wow. What did you do? Why did you push all that? But again, that was my fault. I didn't, and that communication.
Well, that's a big part of leadership. What you just demonstrated is when, and I agree with this, some people don't, but as a leader taking responsibility, regardless of what went on, a good leader is going to take responsibility for those things.
We all have a part
to play, but
it's my responsibility.
The buck stops. Yeah, that's good.
Absolutely.
I was going to say with back to ketamine, medications like that, the dosing obviously is a big deal, and the actual medication itself. There should be a certain amount of humility I think, in giving these medications. We can get really comfortable with things that we do. And, all these medications have side effects, and some of the medications have side effects that we have to be prepared for, and they can happen. Complete respiratory depression, cardiovascular collapse. These situations do occur, and we have to be prepared to do them. Yep. Anytime I do a procedure in the hospital, I have to be prepared for the complications.
Yeah,
if I drop a lung, I have to know how to put in a chest tube.
That's right.
Things like that. It's important that we understand and respect and are humble when we think about how powerful these medications are.
Absolutely. Yeah, I mean, it's not a big deal. A lot of these cases that we've seen with ketamine, like if they would have just controlled the airway, they'd have been fine.
Right.
Throw in an OPA, start bagging the patient, maybe intubate them if your protocols call for that. Like you would have been, the patient wouldn't have died, right? You probably, you might have got your hand slapped, maybe written up or something like that, but maybe you're not being brought up on criminal charges, right? Yeah. So, yeah.
And then we're going to get to it later, and you kind of mentioned it, but making a mistake, it's usually a systems problem. It usually is a systems problem. And if you did you had a lapse in judgment, and you're honest about it, and you own up to it, you take responsibility for it, and recognize the fact, I could do more training, or I could, it's something that is dependent upon culture, I think.
I'm going to look something up because I want to make sure that I say it right. But it's something that we talk about. We don't talk about it enough in the paramedic pre-hospital world, but it was heavily talked about within the nursing world, and it's just culture.
Yes.
Right? And I'm sure you probably are familiar with the just culture thought process, but it's investigate for safety, respect others, embrace different perspectives, be fair, seek improvement, strive for learning, trust. But as somebody in administration, or like from a medical director standpoint, whenever there's an error or something that happens, right? Somebody has a medication error, right? Yeah. I'm looking at it like, okay, what was this? Was this, did I fail you as your EMS captain? Did I not? You're a new paramedic. Right. Did the FTO, did we not properly educate you on how to do drug calculations? Yeah. Was this a system error that maybe we changed the concentration of that medication and we didn't, I didn't tell you that, right? Or was this a negligence failure that you as the paramedic had never looked at the concentration before? Or was this just like you didn't care and you've had a pattern of this behavior and this is an individual problem? And like you said, most of the time, it's probably an educational or a systemic failure.
I think it is.
Yeah. I
think you're right. I had You shared some of your experiences with an error that had occurred. You took responsibility for. I made an error not too long ago. I got a new set of Raptors. Those
the shears,
the shears, and I didn't know that there was a ring cutting device on that.
Oh, you've told me the story. That's funny.
And then I had a patient, when I realized that, I think it may have even been that shift, or maybe one or two shifts later.
You were excited to use your new tool.
I was excited to use my new tool.
Yeah.
I had all the confidence in the world that this is going to be a great experiment. I even shared with the patients, like, this is the new shears I have, and it's got a ring cutting thing on here, and I'm going to fix your ring up right now. We're going to cut it off, and I'll give it back to you, obviously, and you can take it to a jeweler to get fixed. And we went through the whole thing, and I went to cut it. And I know some of us are just listening online right now and can't see me demonstrating this, but when I went to cut the ring off, I wasn't paying attention to where the cutting mechanism was, and I cut her hand so badly, and I made a mistake.
Yeah.
And think about it, and it really was a systems problem. I had a new device. I hadn't practiced it on anybody, and I practiced it on a patient. And obviously I would never make the same mistake again, but I made a mistake.
Right.
And I was trying to fix a ring, which I did fix.
Yeah.
But I wasn't aware of the other end, the business end of that shear. And I cut her hand pretty good, and I had to sew it up.
Yeah.
And she was a nice lady. It all went well, and I paid, had her medical bill covered and everything. But it's a good reminder, though, to remember to learn from your mistakes. Own up to it. Don't blame anybody.
Nope.
And then also let it go.
Yeah.
We tend to hold on to these things, and then it affects our care in the next patient. It's like, oh, I'm so terrible.
Yeah, you're probably better at letting it go than I am.
Oh, I don't know, man.
Oh, really?
Think so? Really?
I think so. You're
so?
you're
Yeah.
more. I think you're more laid back. Where I'm.
Oh, I see
that
what you're
would
saying.
really like when I don't like making mistakes
Yeah,
on things, and it really bothers me, and I have a really hard time moving past it. It's like I'll just dwell on it, which I've heard them say like that's the mark of a really good quarterback is because
Yeah.
you're going to make a mistake. Like you have a bad it threw an interception. Okay, don't let it ruin the rest of the game, man. You made a bad play. Let's move on. It's
heard it.
over. Yeah.
I've heard NFL quarterbacks interviewed and talking about just that.
Yeah.
It's being able to throw an interception and then on the next series completely forgot about it, right?
Yeah.
In between the series, you're looking at, oh, what did I do wrong? How did I not see that coverage? How did I not recognize that defense?
Yeah.
Boy, they schemed that thing beautifully and disguised that coverage. Right. And you missed it.
Yeah.
But you learned something, right? And so that next series you're out there, you're a little better. You're not carrying that weight of a failure with you. It's going to affect your performance, right?
That's right.
So I would tell, we didn't really plan on talking about this, but I think handling mistakes is certainly worth talking about. It's a big deal. It's to me, the way I handle a mistake is I will self-loathe, talk really badly internally. Nobody hears this about myself.
Way to go, idiot.
Right, I'm thinking those words.
Yeah. Oh, 100%.
And I feel terrible, like the worst doctor in the world, kind of thoughts. And it takes me a while to get over them.
Yeah.
It's interesting to hear you talk about that. And from the outside looking in, you think, oh, he's a doctor, so he doesn't make mistakes, Well, you know me because I make mistakes all the time. But,
every doctor makes mistakes. They're humans.
That's right.
Yeah, we all make mistakes.
And the same thing, too, and a patient looks at you as a paramedic and thinks, oh, they're going to save me now.
Yeah.
And they're putting their trust in your hands. We got to do our best to not make mistakes, but like you said, nobody's perfect.
Nobody's perfect.
And we have to live with ourselves. So we talked about medication and dosages
Airway,
and things like
we
that.
talked about medication. 5 R's too. We didn't really talk about this that much.
No, you're right.
We talked about it in the lecture, and we've talked about this before, but it's so important. I would always teach my new paramedics this, that get in the habit. If you're just starting out in EMS, please get into this habit. If you have been in EMS for a while, please start doing this. But make it a habit that I don't care if you're giving somebody an aspirin, right? Verbalize what you're giving. Hey, I'm giving my patient 324 milligrams of aspirin. That's 4 pills. They're 81 milligrams a piece. Expiration date is this. I'm giving them 4 Zofran, right? That way, when you get to that high acuity patient and you're got a push dose going and you've got your ketamine drop and you're resuscitating, you're trying to get the pressure up, and now you're trying to get airway go, all these complicated things going on, right? Then it's habit. Yeah. It's habit to do that, and one of the crews that I worked for a long time, that was just what we did. Yeah. And so it was just automatic. We didn't think about it. It doesn't take any more time to do it that way, and it dramatically increases your chance of success and decreases your chance for error.
And the fact that you could hold on to that process in the midst of chaos, where you have a sense of calm, that's.
But you did because it became a habit.
Right.
We didn't think about it. It's second nature. This is what we do, especially when we're doing IV medications. This is this is our process, and we don't deviate from it.
Yep.
Right. And so that's.
We make 35,000 choices every day,
and
those choices turn into habits, just like you said. That's where we build culture.
That's right.
So then you actually kind of mentioned it, to go back to the 5 rights. That really our next thing that we had talked about in the lecture was communication and closed loop communication and being able to communicate where, I need this. Matt, can you get me this?
Yep.
Sure, Eric, I'll get you exactly what you said, right? And then I'll confirm and say, okay, good.
Thanks.
I'm doing this now. It's like that closed loop communication. But it's not just the closed loop communication that's important. It's also, we talked about it, dispatch, right, is communicating to us. Did we get that information? Yeah. Are we getting information from our patients when we communicate with them? Are we calling it in appropriately and helping the ER prepare? And then how's our handoff? Yeah. All these communication points along the line of that patient care, all so important.
Yeah, hugely important. And communication goes along with assessment. If you're not a good communicator, which one of the things I've seen was, electronic devices. Yeah. A lot of the younger generation, I'll say, communicates through a phone. So face-to-face communication is not really, some people aren't comfortable with it. Right. Well, you better get comfortable with it if you're going to be a pre-hospital provider because, you got to communicate. You got to sit in front of your patient. You got to talk to them. 98%, or is it not? I think it's 98% of all communication is nonverbal. Or is it
the vast majority
Yeah,
of it. I can't remember the percentage, but most
But
of it is
the inflection. It's not just the
the
words that you
tone,
say, the tone in your
body
voice,
language.
eye contact, right? Like if I say, yeah, Eric, I really care about what you're telling me.
Oh gosh! By the way, if you communicated that way, this would be impossible.
Yeah.
This would be totally impossible.
Yeah.
If one of us was disengaged.
Yes.
This wouldn't work.
And I can say the same. God, I really am. I care about what you're telling me today.
Yeah.
I said the exact same words,
Yeah.
but the inflection of my voice is different.
Yeah.
Where I'm looking is different. My body language, and that said way more than the words.
Now imagine being in a life and death situation with a patient and communicating with family, communicating with
Yes.
significant others.
Yes.
That communication is so crucial to have it right
Yes. It's
and to
very
practice that. That's really good, Matt.
Yeah.
Language barriers is a big deal too, right? We talked about that as well. We live in a culture with lots of cultures in it.
Oh, yeah.
Lots of languages, different languages.
Yeah, it doesn't matter where you live. There's going to be probably somebody that doesn't necessarily speak English, at least not their first language. So, yeah, utilize your resources. We talked about AI a little bit,
AIs.
that's going to come along.
Yeah, that's a good thing. I mean, AI can be good and bad.
Yeah.
I think communication is certainly good with the language. It's never going to help you with culture.
Nope.
That's different.
Yep.
Different cultures have different practices, and
First time
social
you see
norms.
a 5-year-old with cupping
Yeah.
signs on their back, and you're thinking, "Oh my gosh, they're
Abuse.
beating this kid."
Yeah.
Nope, they're trying to heal the kid. Yeah.
Or you walk. Yeah, there's all sorts of different cultural norms that could. Boy, if you don't understand them and are sensitive to them, you could really shoot yourself in the foot with communication and just blow trust out of the water.
Yeah.
But being sensitive to those things and showing respect to those cultures and understanding a little bit. I'm not saying it would be impossible too to memorize everything about every culture.
Oh, yeah, you're
but
never
know
gonna
your area.
Yeah.
There's certain cultures that may be in your area where you're going to encounter them. Be good to understand them a little better.
And most of the, I find that if you're just like nice and patient and calm, like you don't need to know all the nuances about every single, but if you're nice, like people, even if they don't speak English, again, body language, they can see that you're confident, you're calm, you're trying to communicate, you're doing the best that you can do. And they realize too that this is an emergency situation and you're trying to do the best, where if you're freaking out and panicking, right? Doesn't matter what language you're speaking, people can read that. So
No, that's not good.
another big factor to communication for sure.
We mentioned briefly, and it comes out too in our documentation lecture and the error lecture, but is the things, the system errors that we have, and one of those is cognitive bias. Like we tend to want to have tunnel vision.
Yeah.
You've got this patient that was dispatched as an MVC, so you're just thinking trauma. Well, you may miss the fact that the reason they got in the car accident was because they had passed out at the wheel because of some other medical issue.
Right.
It's complicated, and I think that the tunnel vision can really shoot yourself in the foot with assessment, anchoring. Sure. We talked about that.
Or just using your initial assessment as like, okay, that's what the problem is.
That's right.
And never, oh yeah, well he, is on some drugs or he's intoxicated. Well, oh, I forgot to check a blood sugar. Like you thought he was intoxicated and you didn't even do your due diligence of checking a blood sugar, right? Don't, constantly reassessing your patient, right?
Oh, that's huge, yeah.
For improvements on whether improvement in their overall condition, on
right.
any of your treatments, is that helping or not helping what's going on with your patient? Very important.
And, we're going to kind of bridge the gap from the errors to, strategies to prevent errors. But one of the things I think as far as the error producing things is the culture.
Yeah.
This is really important because if you're in a culture where you're not comfortable to share a system error you experienced, you're going to hide it. You're not going to communicate it. And it's we talked about this actually. An error that you don't disclose is a permanent error. It's never going to change.
Never going to fix it.
So, and I understand. I've been in some bad culture environments where you're not going to share anything because you're going to get ripped apart, and because of culture issues, people aren't comfortable sharing them. It's just easier just to hide it.
Be macho, be cool. I'm the smartest guy in the room. Yeah,
Right.
No, you're not.
Yeah,
No, you're probably
that's
not.
another that's another way to look at it. It's hard anyway, but culture's big. So, prevention. how do we prevent? No, actually, I think documentation. We never hit documentation.
Well, documentation is another big, high risk area, right? That we have to document correctly.
Yep.
Right, and there's a lot of reasons why we don't. Fatigue, bias, all these different things can play into why we don't document correctly. It's 2 a.m. I'm on my 15th call of the shift. I'm exhausted, or I've run on this guy 10 times in the last month. Right, I'm tired of dealing with this guy. Right, but that's no excuse.
No, it's not, and it's and I love what you said. I say it wrong. You say it right.
It's not what you do; it's what you document.
Exactly.
Yeah.
And I think it's almost, it can't be separated. If you're the best medic and you don't document, then
you're not the best medic.
You're not. Yeah, that's right.
Yeah. And you can be, it's like, you can be a subpar paramedic and document really well and make yourself look really, really competent.
Yeah.
And I've seen on the flip side, and the problem is that as the more experienced you get, the more comfortable you get with patient care, the better you get at patient care, the worse your documentation becomes. At the beginning, you're really detailed. And then you start to get complacent or overconfident, and then your documentation goes down.
Yep.
And the documentation needs to be at a high level, right? It needs to maintain that.
It's like eating your vegetables. It's like nobody likes to document, but it's really important that we do it, and it's got to be good.
Guy, though. I don't like eating vegetables.
Well,
I know.
You need the micronutrients, Matt. You need it, and I know we're not talking.
You don't get that from steak?
No, there are micronutrients there. Well, actually, I think it's just like you have a balanced diet.
Yeah.
I think if you're uber focused on documentation and you're losing sleep because you're not going to provide great care to the next patient you've got, or you're going to get so far behind in your charting, you're going to end up forgetting things.
Never going to be effective.
It's a balance there.
Yes.
It's always a balance.
Yes.
So, and if you're using an AI tool to generate your narratives, be careful.
Yeah, double check what it's saying. Yeah, AI hallucinations is a real thing. Yeah. So double check. You don't ever just, I did an AI generated narrative, I'm good, without reading it, because that comes up to another documentation error, is conflicting information.
That's right.
Right? Something that's in your flow chart, something that's in your primary impression or whatever contradicts what your narrative said.
Yeah.
Oh, okay, that's a problem, right?
No, that's so true. That's so true. Well, it's kind of funny as we talk about the different things that can cause errors, doing the flip side, like closed loop communication or having a good culture is really a preventative strategy. But one of the preventive strategies we haven't really talked about is teamwork and trust. I think that's part of culture, I suppose. But remembering that you're not on an island.
Yeah.
You're with a team, communicating appropriately with your team and leveraging other brains in the room.
That's right.
Like you said, calling out the dose you're giving.
Yeah.
And wait, hold on a second. That didn't sound right.
Yeah. How much time?
Oh, shoot. What was I thinking?
Yeah.
Kind of a thing.
I meant 10, not 100. Yeah.
Yeah.
Well, it's like for my fire guys out there, right? And I talk about this, that you don't fight a structure fire by yourself, right? You're not going to get water on the fire.
Yeah.
You're not going to do forcible entry and search and ventilation and utilities and overhaul. Yep. You're not going to do all those things by yourself. It's impossible, right? You have to work together as a team, and all that is inherent upon communication. Right?
So crucial.
Communication between crews, communication with command, and it's an it's a well orchestrated machine. And if everybody does their job right, it's like Bill Belichick used to say, just do your job. Just know your job and do your job, and we will win, right?
Yeah.
But same thing goes here. Like if you're running a cardiac arrest, you can't you got to have more. I mean, some providers, unfortunately, you might only have yourself and your partner. Yeah. And you do the best you can with what you got, right?
Do the best you can.
But if you have more people, like communication is the key to success there.
And being willing to be aware of, you have to be aware of mistakes, but being willing to do something about it, right?
Yeah.
Like you said, there's also a stigma of, not wanting to change.
Well, nobody wants to, especially in the fire service, nobody wants to say that they don't know something.
Right.
I don't want to say that I'm not as smart as you are. Right? Nobody wants to say that, right? We all have this bravado that we have to keep up, right? And we kind of need to go away from that because there's no way you're going to know everything, right? You're a brilliant, smart guy doctor, right? I know for a fact that you know way more about medicine than I do because you went to school for 12 years to learn it. I went to paramedic school for 6 months. There's no doubt that you know more, right? So I have to humble myself to say, teach me, right? But I'm sure that you don't think for a minute that you know everything.
No.
We go to Dr. Yu or Dr. Gare and learn things.
Well, and actually even you know your environment better. I have learned so much being a medical director about the environment that you're in and how to do that paramedic job a little bit more effectively, a lot of the things that, these other pieces of knowledge and information don't really matter.
Yeah.
And learning and understanding your role in an ambulance has helped me to be a better medical director, to really get it.
Yeah.
I think that's a big part too, and being willing to consider another perspective.
Yeah, that just because you're a doctor doesn't mean you understand my world.
That's exactly right.
Yeah, it's very true.
So I think that's an important part of it. But beyond awareness, I think there's this willingness to be able to learn from the mistakes. I think remembering that any mistake that you might make is an opportunity for
growth.
Yeah, make your department better, improve patient care, improve yourself. I mean, these are all positive things.
Yeah, we got to put our ego down and be willing to review calls. If somebody comes to a case review, like instantly everybody gets their guard up, like, here comes the medical director. He looked at one of my cases. Like, no, he wants to come educate you. Like, hey, what were you thinking here? Tell me what you're. Don't get so defensive, right? Be open to learning something new.
Yeah, we're all different.
Yep.
With you and I know we work together a lot, right? So I tend to be more of I'm willing to change things and to
you're
take
fly
a
by the
risk,
seat of your pants.
Yeah.
I'm like, whoa, where's the step-by-step process of how we're doing this?
Now, it's interesting, though, we actually last week when we were in the studio filming, we had an interesting experience, right? I tried something new with our content to try to improve things.
And I hated it.
But you're honest, like, because I did try to change, because we don't need to go into the details with content development, but there's a lot of research.
Oh, yeah.
There's a lot of time with graphic design, in multiple states. I mean, things are getting passed around.
Thank you, Eli.
Yeah, thanks. Thank you. Go Detroit. And then we have editing and auditing, and there's a lot that goes on. So I was trying to improve the process, and in the process of me improving the system, we get into the studio, and you felt comfortable saying, hey, I know you spent a lot of time on this, but I don't like it, right? And I could have been butthurt, right?
Yeah.
And said, well, hold on a second. I put a lot of effort into this. What are you talking about?
Yeah.
But what happened? You first of all, let me back up. You said it in a way, too, that was respectful and kind and like,
hey, idiot. What's this crap?
But you know what? Actually, you could have said that, and it probably would have been okay, because we have a relationship with friends, right?
So, and you didn't know I was joking anyway.
Yeah, and we both have a common goal, right?
Yes.
We want to create excellent content to do help improve patient care. So when we kind of have that common mission, right?
Yes.
It was easier for me to receive it and listen. It's like, oh, okay, yeah, I think Matt's got a good point. Instead of thinking to myself,
who's he to tell me I created this PowerPoint? Right. Yeah, I did all this work.
But what is that? That's culture, right?
Yeah.
And then what did we do this week?
Yeah, we changed it.
We changed it.
Yeah.
And then you're like, hey, that's a whole lot better.
We all thought it was better.
Yeah. But when I got the original product back from Eli from Detroit, I didn't like it so much.
Yeah.
I had to change it because I thought we went too far on that spectrum, and we brought it back a little bit. And today, I think things were so much better.
Way better.
So there's a lot of teamwork involved.
Communication.
Devin behind the cameras involved.
Yep.
Communication, culture,
Yep.
where we found a systems problem. You felt comfortable communicating it. I received it, heard it, and responded, made things better. And now this week, we actually took some big steps forward. Not only does it save time and content development, it makes it better.
Yeah.
We're actually doing something better now because you felt safe to say it.
Right.
And I felt like I could receive it. And we could reverse the roles too, right?
Yeah.
We could have a reverse conversation, and you would, maybe I feel comfortable talking to you, or, anyway, that's culture.
Yes.
And we could talk about mistakes till we're blue in the face. We're all going to make them.
Yep.
How we handle them as culture. And I think that's probably, well, not more. I don't think there's anything really more important, but if you have bad culture, the mistakes that are going to happen inevitably, we're not going to get better.
Yeah. And let me say, like, especially in the fire service, your culture is not created by your admin. So your admin is not in the fire station every day. Right? You create the culture at the station level. Right? Now, I can create the culture as somebody in admin or in a leadership position of learning right? I'm creating a culture in the classroom of if we're going to cover a certain topic or we're going to work a certain scenario.
Right.
And I think that's what makes you and I good instructors is we don't have big egos, and if somebody asks a question that somebody might look and go, well, that's a dumb question. Well, you know what? Maybe this guy's been a paramedic for 2 months and he doesn't know that.
Yeah.
So I am never going to make, even if somebody says something that's maybe a little bit off and everybody else might be like, hey, no, that's a good question. You know why? Because you didn't understand it. You had the balls to ask the question. I'm going to acknowledge the fact that at least you're trying to interact.
Say that to them.
Oh, I do all the time in my.
Oh, you do? Oh, that's cool.
Absolutely.
I love that.
Oh, no,
That's
I'll
cool.
absolutely say that. Like, I appreciate the fact that somebody
you have
has
the guts
to speak up. And a question that some people might go, well, that's kind of a dumb question. You didn't know that? When the reality is that probably 80% of the people in that room didn't know that. Yeah. But they're looking like, way to go, idiot. I'm sure glad you asked that question because I was wondering the same thing. So then you applaud that. Hey, great question. No, it's not. I know this might be a stupid question. No such thing. Only stupid people. No, I'm just kidding. No such thing as a stupid question. If you don't know it and you don't understand it, then ask.
Right away, too.
Yes.
We talked about this in the lecture with football analogy,
Yes.
right? You're implementing a new scheme for a team that you know you're going to be playing that next weekend.
Go
and
Bears.
When you first implement it, right, the Chicago Bears implement a new scheme because they're playing the Dallas Cowboys.
And you got Ben Johnson, baby.
There you go. No, but you implement a scheme. When you're implementing a new scheme, a good coaching staff is going to implement that thing in a way where they create a safe environment to make mistakes and to try it out. And oh, wow, I'm going to have to change the way that my footwork here as a lineman to get that block. This is going to be a tough block for me.
Yeah.
You know, and so we can make mistakes as we are starting to implement that scheme.
Yeah.
But man, the day before game day, when you're doing walkthroughs, this is not the time to try to figure things out, right?
Yeah, you work all the bugs out. This is the plan. You know your role. I know my role. Execute.
And so there's a lot of awareness in our weak points. There's a lot of being willing to admit that I'm weak here and I need to work on this.
Yeah.
So we don't have a mistake at game day.
Yeah.
Right. And if you do find a mistake at game day, looking back, it's like, how did I miss that?
Yeah.
Oh, wow, I should be doing this.
Yep.
Right.
Or if you do make that mistake, moving on from it.
And move on.
Okay, screwed up. Let's move on to the next play.
Mistakes.
Yeah. Let's move on to the next play.
And don't be dishonest. Don't make those integrity mistakes because that's how you get fired.
That's how you get disciplined. Everybody talks about that. You make a mistake, you're not going to get fired 99.999% of the time.
Yeah.
You are not going to get fired for making a mistake.
That's right.
You're going to make a mistake and then you're going to do something dishonest around it. You're going to falsify your documentation. You're not going to tell the doctor at the ER that you made a medication error. You're not going to tell your EMS leadership, hey, I screwed up here. Whatever the case may be, that's where discipline's going to come in.
Yep. Or the integrity to not own up to a mistake and to be hubris or overconfident or arrogant about it.
Yes, that's what leads to the discipline is because it's an integrity character issue.
Right.
We know you're going to make a mistake because you're a human and you're in these high acuity, life-threatening, high-stress, very fast-paced environments. Mistakes are going to happen.
Low
it's the
frequency,
reality.
too, and that's what really creates the problem.
Yes, you don't do this all the time, right? So we know mistakes are going to happen. So if you make a mistake, own it. We'll learn from it so that the next time will be better. But boy, you try to lie about it and hide it. First off, let me tell you something. They're always going to find out.
Always.
Always going to find out. And then you don't want Bill Bonney coming after you.
No.
I don't want Bill Bonney coming after me. That scares me.
Yeah, so people listening probably don't know who he is, but he's...
Oh, some people do.
Oh, yeah, I'm sure
some people,
a lot of people probably do. The guy's like
he's
he's leading the task force right now.
Oh, yeah. He's led lots of stuff. Committees around here.
But internally in the department where I'm a medical director, his expectations are super high.
As they should.
And I like to... I just like having that expectation set where people don't want to cross Chief Bonney.
Yeah.
Right? No. And they really don't want to let him down.
Yeah.
A lot of folks have shared that with me.
It's respect.
It's respect.
Yeah.
But keeping the culture to where you're not afraid to make a mistake,
right?
Where you're just trying to comply with protocols and just watch your P's and Q's and just make sure you don't mess up. That's not the way to function.
Yeah.
it's a commitment to being the best you can.
Yes.
And to performing in a way that's like you're treating your family.
Yeah.
That's really the goal.
Yep, for sure. Yeah. Well, we've talked a lot about different errors, potential errors. And then let's talk about prevention. So how do we prevent these errors?
Well, I think again, a lot of this is reiteration. But if I had to pick one thing in our department to prevent errors, because they're going to happen, and
go our brothers and sisters.
That's right, I hear
Go get them, brothers.
The errors are going to happen. We've established that. We're not perfect. We are human.
Yeah.
And culture is going to help us to either communicate those errors or handle them, hopefully in a way that's constructive, as an opportunity to change.
Right.
But I think sandwiched in the middle, like my favorite part of an Oreo, right, is the creamy good stuff. Anyway, I don't know where the Oreo analogy came from, but my point is,
you got to have a double step,
training
yes.
is training. It's something that I think we could probably have a whole podcast just on training alone.
Oh, for sure.
Is being prepared for those emergencies when they happen, because the training is a big part of the system in education, in training. Being prepared with scenarios and knowing that these low frequency, high stress events are going to happen eventually, and we want to be ready for them to create a learning environment where we can train properly. So I think training would be, I think, one of, as a medical director, the most important things that I can help to facilitate to minimize errors that are going to get, they're going to affect patient outcomes.
Don't train on it till you get it right. Train on it until you can't get it wrong. That's the way you want to look at it.
Right, and I think that, it's one thing as a medical director to teach somebody, but when I can teach it to my paramedics to teach the newer ones.
Oh yeah, for sure.
What is it? Do one, learn one, teach one.
Do one. Do one. Sorry, watch one, do one, teach one.
Yeah.
Yeah.
That's it. So I think training would be. What would you say most when you think preventing errors? I'm thinking training.
Yeah, training is a huge part of it, right? You have to be trained on the skill that you're doing. But when you're actually doing the skill in the environment, sure, you're going to fall back on your training, but having a checklist, right? Having a checklist that in the moment, because we've talked about system 1 and system 2 thinking, we don't want to be in system 2 thinking, because we're talking about high risk calls, right? We're not talking about somebody that we've got some time on. We're talking about, we just showed up on a 5-year-old who's got a crashing airway, and we got to make a decision right now. Are we going to tube this kid? Yeah. Right? And we got to get all this stuff in place, right? Huge. And so if you have a checklist, we have to be in system 1 thinking, because we have to just act. Right? And so having a checklist will make sure, because there's problems with system 1 thinking. They're prone to mistakes because you're overly confident. I know what my drug dosages are, but I'm not going to forget to check the blood sugar. I'm not going to forget to put end-tidal on my tube. I'm not going to forget whatever the thing is, right? I'm not going to forget to push sedatives before I push my paralytics, right? So having a checklist, right? So like we have a high-performance CPR checklist, right? We have an RSI checklist, a resuscitate before you intubate, right? What's your pulse ox at? What's your blood pressure at? Are they sitting at 80% and you've been bagging for 5 minutes and you can't get it up? You really want to push that? Sucks. I mean, maybe you have to. It depends on the situation. What's their blood pressure, right? Well, whoa, hang on. What do we, So checklist of things so you don't make a mistake in the moment, I think is super important.
And those checklists of critical actions.
Yes.
Those types of mistakes can be really devastating. It's a good point. It's one thing to give a little too much or maybe make a miscalculation. That could be a bad error too.
Give a little bit of morphine, probably not going to kill somebody.
Right. But not getting that EKG and recognizing the fact they're having a STEMI when they called for weakness.
Right.
That type of an error could be mitigated by a checklist. Just remembering to do those critical actions.
That's right.
That's really good.
Yeah, I think that's probably the best. Again, in the moment, heat of the moment on these calls, that's the best way to prevent some errors. And just having good habits, right? Like we talked about with communication, with the 5 rights, those kind of things. I think that's super important. If you create good habits, that in combination with experience and then checklists and training, you're going to be good.
Now, I answered your question, which is a great question, by the way. from a medical director perspective, but I would answer it differently from a practitioner's perspective. So internally, personally, for me, as the one who's responsible for my actions and not wanting to make mistakes, not wanting to be in that situation where I'm like ripping myself apart because I made a mistake, wanting to avoid that at all costs. I would say that the most important thing in that is really a sense of, I don't know if it's humility or just the just being willing to admit the fact that there's more to learn.
Yeah, humility. Yeah, I'd say that's humility.
I think that might be something maybe internally for all of us. Is like you get a team of people all feeling that way.
Yeah.
Where we got more to learn here from each other and from the literature and from our medical director, from our chief, our FTO, is not feeling like we've arrived.
Yeah.
There's always more to learn. There's always some rough edges to sharpen. I think that might be another thing I would say would be most important. I think internally, not as a leader in a department, as a medical director, but more as just personally for me as a doctor, is always being willing to relearn and reevaluate, look at new literature.
You have to. Like when I went to paramedic school 20 plus years ago, like we didn't do tourniquets back then. That was like oh my God, you don't put a tourniquet on somebody's arm, right? Trauma patients, 2 large bore IVs, give them all the fluid you can give them.
True.
You know, so you have, but I think, again, the problem with a lot of especially fire-based EMS folks is, well, I went to paramedic school and I learned it, now I'm done.
Right.
And it's like, no, you're not. You are, if you're not constantly learning current things, you're doing yourself and your patients and the community a disservice. Period. There's no question about it. Because if you're basing your patient care off of 20-year-old medicine, you're way off.
Yeah.
And that's just
Things
the reality
change
of it.
fast. And they're changing faster now, I think, with the more AI and ChatGPT and all this like information.
Well, and they're changing faster with pre-hospital because they're doing more data and research in the pre-hospital environment, which before they didn't. And especially, I think, since 2020, they're doing more and more like, whoa, these guys can have a dramatic impact on patient care. We need to study this. We need to study that, right? And so, if you think you know it all because you went to paramedic school 15, 20 years ago, no, bro, that's a bad mindset to have. Yeah. You need to change that.
Well, it's been a good podcast, man. A lot of good reminders. We all make mistakes. We're not perfect. We need culture. We need to work together.
Need to train.
Gotta be honest and humble. Train.
Communicate.
Really good. A lot of good information here. I hope our viewers and listeners.
Well, I think if they're listening to this podcast, they're doing a lot or most of that, or they're on the right path at least.
I think so.
Not because it's us, but because they're listening to a podcast that's going to help them grow.
So you can close the loop by doing your assessment questions for this podcast.
There you go.
And then show us
if you're getting CE credit for it.
If you're getting CE credit.
Yeah, if you're not getting CE credit for it, shut it off and move on to the next one.
Yeah. Be safe out there.
See you on the next one.
Thank you for listening to EMS, the Erik and Matt Show.